Hello, and thank you for joining us for the 49th Annual AAKP National Patient Meeting. We hope you have been enjoying the sessions. My name is Jerome Bailey, and I have the honor of serving as the AAKP Director of Patient Engagement and Advocacy. In this role, I am responsible for helping to develop and implement strategies to enhance patient engagement, support, and advocacy initiatives. I have the pleasure of working closely with patients, care partners, healthcare providers, and other stakeholders to drive AAKP's mission to improve the lives of individuals affected by kidney disease. As a proud member of the AAKP team, I firmly believe that every kidney patient's voice is paramount in determining their care plan. It's essential that we cultivate an environment that encourages kidney disease research and innovation, driving continuous advancements in care, improved treatments, and solutions for unmet patient needs. Once these innovations receive FDA approval, it is equally important that all patients have access to and the right to choose the best treatment for them in consultation with their chosen healthcare team. This ensures every patient can live their best life and achieve their aspirations. With that, it's my honor to introduce our next session titled Disease Management, How to Reduce Risk of Falling, which will be led by Dr. Stephen Fadem, Chair of the AAKP Medical Advisory Board and a clinical professor of medicine at Baylor College of Medicine. With his extensive experience and deep expertise in nephrology, Dr. Fadem has been a cornerstone of our medical advisory efforts, providing invaluable guidance on best practices and patient care. Dr. Fadem was one of the first doctors to discover the value of the internet for patient education and founded several websites dedicated to public service and the dissemination of clinical information, including the Nephron Information Center, WikiKidney, TouchCalc, and dialysisunits.com. Dr. Fadem is the recipient of the AAKP Visionary Award, the AAKP Peter Lundin Award, the AAKP Medal of Excellence Award, and the President's Volunteer Service Award. Today, Dr. Fadem is going to dive into the important topic of reducing the risk of falls, especially for those dealing with kidney disease. Falls can be a big deal, so learning how to manage and minimize these risks is key to living your best life. Dr. Fadem, welcome to the program. I turn things over to you.
Thank you, Jerome, and thank you, AAKP, for having me. It is a pleasure to be here at this 49th annual AAKP meeting. Today, we are going to talk about how we can reduce the risk of falling. Our objectives are to answer the following questions. Number one, why do people fall? 2, what are the 3 types of falls? 3, what are the 2 kinds of falls? And finally, how can we reduce the risk of falling in both chronic kidney disease patients, ourselves, and in the elderly, ourselves, and for some of us, especially me. And I have no disclosures whatsoever. To introduce this topic, there are over 33% of people over 65 who fall each year. Over 80 years old, the number jumps to 50% of people that fall. It is the leading cause of injury in the elderly. 50% of accidental deaths. 20 to 30% of falls lead to injury, such as head trauma, hip fractures, or lacerations. Falls are 3 times as common in the dialysis population. So we still have that question, why do people fall? For every why, there's a why not. So if we can figure out why we fall, then we can reverse engineer that to come up with a conclusion that we shouldn't fall. Maybe we can prevent falls. So we always want to know why we fall so that we can come back and say, well, why not fall? How can we prevent it? We want to prevent and fix what we can, but we want to be able to prepare and adapt for the things that are inevitable, inexorable, that we cannot fix. Remember, there are 2 kinds of falls. There's mechanical falls, which are caused by changes in our health, and are not caused by changes in our health, but caused by changes in our environment, such as slipping or colliding or falling forward. And there's non-mechanical falls, such as health problems. And some of those we can fix as well. So let's start with the elderly. And I include myself in this group. It's something that we all experience if we're fortunate enough. And it's something we have to adapt to. And there's just nothing else I can say about being older than you have certain adaptations that you have to make. For some people, the adaptations are less fortunate. Cognitive disorders, strokes, dementia, and perhaps frailty are things that people have to be concerned about. And those are some of the main reasons why people fall. And the big group as to why people fall is the cognitive disorder group. The second large group is medications. Medications include sedatives, sleeping pills, blood pressure medicines, diabetes medicines, and especially sedatives. And sedatives also include antidepressants and painkillers. And then the third group of falls for the elderly are medical conditions, a gait or a balance disorder, eyesight problems, vision problems, not being able to see, losing your peripheral vision, muscular or bone or joint disorders that can cause weakness or trouble with brittle bones, arthritis, cardiovascular disease, dehydration, heart failure, and rhythm disorders. And anything which can cause a decrease in physical activity, such as laying in bed too much, not getting out of bed, not feeling good, anything which keeps us supine is going to cause us to have a higher risk of falling. Why do kidney patients fall? Well, many of the same reasons: cognitive disorders such as a stroke or dementia, medications such as sedatives, diabetes medicines, or blood pressure medicines. But in the third group, it's a little bit different. Not only do we have loss of balance, disordered gait, but we have diabetic eye disease, because many of the people who have kidney disease also have diabetes, and that causes damage to our eyes. Bone loss and muscle loss are really common in kidney patients. Vascular tone and heart failure are big problems in kidney patients. Neuropathy is a big problem in diabetics. And the blood pressure can fall after dialysis, and that's one of the most common reasons why people fall. So let's talk about mechanical falls. And this is symbolized by a banana peel on a very slick marble floor. It's a perfect setup for somebody who is unaware or who may have a balance problem to fall and slip and really injure themselves. So bad footwear, slippery floors, ice patches, and you may not have them in your house, or you may not have them in your yard living in a place like Houston, Texas, but the people in the north are plagued by ice patches. The only time I fell in the past year was in Norway, and I fell on ice, tripping over clutter, loose carpets, not using a walker or a cane, uneven surfaces, surprise steps, not using handrails, no night lights at night, and glare all can cause a mechanical fall. Now, just because you have a mechanical fall doesn't mean you're going to get hurt, because when I fell on the ice, I caught myself and I was well padded and I was prepared for it, because I was up in the winter in Norway taking pictures of northern lights, and it was freezing cold, and I was ready for the fall, and I caught myself, and I was mad that I fell, but I wasn't hurt. And I felt good because my 35-year-old coach that was helping me take pictures also fell So I didn't feel so bad that this old man fell. What are the characteristics of a fall? Well, some of the characteristics are in the dialysis population. 73% of dialysis patients who fall will fall after their dialysis procedure, having a low serum albumin, sarcopenia, which means muscle weakness and muscle breakdown, low vitamin D levels, which damage bones, and a low pre-dialysis blood pressure can all cause dialysis patients to fall. Mechanical falls in the non-dialysis patient or in the dialysis patient, it doesn't matter, can occur at home 82% of the time. 69% of people who do fall in their homes fall indoors. They don't fall outdoors like you would think. And most of them are walking when they fall. 31% are standing, and 16% are in the bathroom, particularly taking a bath and standing up after being in the hot tub. It causes you to lose your blood pressure, your balance is off. If you don't have guardrails, you can really injure yourself. This bathtub is a perfect place to really get hurt. What are the consequences of a fall? Well, I'm going to mention two major consequences. Number one is a hip fracture. Now, when we talk about the hip, we don't talk about that big giant pelvic bone, which is the hip. What we really are talking about is the shank bone, or the bone of the upper leg that has a ball and a joint, and the ball and joint, the break occurs right across that joint. It's a very weak part of the shank and of the femur, and it can cause a fracture. The shank part, that's not the shank part, it's the neck. The shank part can also be the victim of a fall, but less common than the actual neck. The reason people fall with bone disease is that their bones get weaker as they get old. The cells that break bones down seem to be more plentiful. They're aggravated by inflammation, and they're aggravated by age and a lack of vitamin D. So people with kidney disease and the elderly have a high incidence of bone disease. And they find that a risk of a fracture is higher in chronic kidney disease, period. And it doesn't matter what the GFR is. In fact, even with GFRs less than 60, you have twice the risk of falling, probably because you're more active at that GFR, but you're still more prone to fall. So you have to be careful if you have kidney disease that you don't fall. The next slide is a little bit more serious. These are the head injuries. They're most likely from a fall. 62% come from a mechanical fall, not a stroke or not hypotension, but a mechanical fall, tripping or slipping, stumbling, colliding. The 16% of the falls that require a patient to go into the hospital happen on stairs. So falling on the stairs is a very serious problem, and it is more likely to lead to a head injury than something else. And 10.2% can involve furniture. 4.1% would involve ladders and scaffolds. And we say, well, why would an older person get on a ladder? But trust me, people my age and myself included do sometimes have to climb a ladder. So if you climb a ladder, be very, very careful. Have somebody nearby. Make sure that ladder is secured. Don't get on the top shelf, and keep one hand on the ladder and do what you need to do with the other hand. If you're grabbing something, have a bag up there and put it in the bag as quickly as you can. Be very, very careful when you're on a ladder. 13% of falls are very bad. And of the patients that go into the hospital, 13% of this group of patients dies. So falls are something, they're very, very serious, something that we have to be aware of. There are several types of falls that involve the brain. Number one is a contusion. That is a fall that causes bleeding inside the brain. A concussion It's just where you hit your head and you have a little bruise. And a hemorrhage with free blood, there's three types. One is called a subdural, the other is called an epidural, the other is called a subarachnoid. And basically that determines the part of the brain where the bleeding occurs. All three are very bad. It's important that we're very careful not hitting our head and not falling, particularly if we're on a blood thinner. Some of the other injuries that can happen with a fall are spinal cord, vertebral fractures, a forearm or a hand fracture, lacerations, and shoulder injuries. Vertebral fractures can happen because the spine can be very brittle, and you can have a compression fracture. You can step too hard when you land after a fall, and you can compact your back, and you can have a nerve blockage, which can be very painful. So what about non-mechanical falls? This is the person that faints, or somebody that has a change in their blood pressure or has a cardiac arrhythmia. These are called non-mechanical falls. And the first group of non-mechanical falls is likely to be the patients with frailty, people who've had a stroke, or people who have had dementia. And of course, there's a difference between each of those. Frailty can happen to older people where they stop eating. It can happen to young people too with a serious illness, where you stop eating, you lose all energy, you become very weak. The second group is a stroke, where you have a circulatory problem that leads to a lack of blood reaching your brain. And the third is dementia, which is a chronic problem where you start losing either memory or other functions, executive functions, and you don't function well. And we see that's called dementia. So frailty is a big cause of falls, either frailty alone or frailty associated with hypertension, or associated with an odds ratio, with the odds of falling. If someone says, well, what are the odds of falling? Well, we've actually got that number. The odds of falling is 8.52% if you're frail, which means you have about 8 times the chance of falling if you're frail, but it goes up. The odds is 12.24% if you are frail and have hypertension. You have an odds ratio of 12.24. So you have a high risk of falling if you have a high blood pressure and you become frail. Frailty is very common in the kidney population, and like I said, it's characterized by weakness. You feel exhausted, you walk slow, you don't eat, so you lose weight, and you just don't feel like doing anything. You become very inactive. It's because of several factors: poor nutrition, uremic toxins, muscle weakness, inflammation, and heart failure. And what are the risks? That when you are frail and you fall, you have a risk of a fracture, a head trauma, or of dying. So it's a very serious problem. What about strokes? Strokes can be associated with chronic kidney disease and a decreased glomerular filtration rate. You either have the traditional risk factors from a stroke, which can be high blood pressure, too much salt, atrial fibrillation, where the top part of the heart beats erratically, a cholesterol disorder, and diabetes. The non-traditional can be a genetic susceptibility, such as low nephron number, or the same thing that can cause kidney failure, uremia, an oxidative stress, high uric acid levels, where the lining of the blood vessels don't work. That's called endothelium, is the lining of the blood vessel. It doesn't work well, and it can cause a stroke. And mineral diseases, mineral and bone disorders, and the reason they do it is they cause vascular calcification. If you have trouble metabolizing minerals such as calcium, the calcium won't go into your bones, it'll go into your blood vessels. And that too is dialysis related. as is inflammation, heart failure, what we call left ventricular hypertrophy, or a big ventricle in the heart, where the blood vessels become stiff, where the blood pressure becomes erratic, and where there's a decline in the blood flow to the brain. All these things are associated with a stroke. And so strokes can be associated with progressive chronic kidney disease. It can either be manifested by an acute stroke, by small blood vessel disease, or dementia. They all seem to run together at a certain point. Strokes are very common causes of falls. Post-stroke patients have the highest risk of falling. 37% fall within the first 6 months, and by the year, 73% of people who've had a stroke have fallen. Why do people fall? Balancing gait, muscle weakness and dysfunction, vision and cognitive disorders, and lack of home modification. In other words, if somebody in your family has a stroke, it's very important to change their home to make it safer for them. What about dementia? Dementia is characterized by a loss in brain cells. And the reason we're concerned about that is that the kidneys, the glomeruli or filters in the kidneys and the brain cells are terminally differentiated. In other words, you're born with a certain amount of brain cells, you're born with a certain amount of kidney cells, and as you get older, these wear out, and by the time you reach a certain age, you may not have very many brain cells or many kidney cells left. And unlike the skin, they don't regenerate, whereas the skin will regenerate all the time. If you cut yourself, you'll grow a new part of that skin, but with the brain and the kidneys, you don't. When they looked at 10,308 individuals in the United Kingdom, they found that dementia was, the mean age of it was 78.1 years old, and that it was associated with baseline health factor problems and socioeconomic factors. And when the glomerular filtration rate dropped below 60 and a high heart rate, that too was associated with dementia. So if you adjust the kidney function for stroke, and then it has a hazard ratio of 1.42. So you have a higher risk of a stroke if you have kidney dysfunction, your kidneys don't work. What about age? This is a major problem as we age, of course. And the other problem is that the filtration rate, the glomerular filtration rate, may not truly represent chronic kidney disease because the kidney may be overworking and it may be masking kidney disease. You may not realize you have kidney disease. The only way to tell exactly what's going on is to know what the number of kidney cells are that are left over. And we're working on that, but right now it's very difficult to get that number. We can estimate it by looking at the x-ray because at an ultrasound there's thinning of the cortex. But for the most part, we may not understand as much about kidney function as we would like to, and that can be misleading. Well, dementia is also associated with mobility and balance problems. It's associated with troubled judgment. Patients can't really understand where the dangers are. And so they'll walk into a dangerous situation without realizing it. They get confused with their medications. It's hard for them to communicate. They wander. They're older and they have dementia. They don't know where they are. They just wander around. They start walking around confused as to where they are. And that can be very dangerous. They can get into a street, into an unfamiliar street, and it's very easy to get injured. And it's very easy to fall. Poor memory makes it very challenging to do anything, to get around, mobilize, or to try to get things done. And we like to have older patients try to work on their memory and also use memory aids. The best memory aid in the world right now is the iPhone. Many people have a chip inside the iPhone so they don't lose it, so they know where it is. But once they find it, they have their things to-do list. They have all kinds of information in there that helps them get through some of the challenges of dementia. Dementia can be associated with depression, with urinary incontinence, with vision trouble, for depth and vision perception. And if you become forgetful, you forget to pick your clothes up off the floor and they stay there and you trip over them. Or you forget about that step, that little surprise step that when you built your house 50 years ago, you thought it would be cool to have the patio go down, have a little sunken patio. Now it's different. Now it becomes a liability. You have to be very careful. So what about medications? Well, there's three groups of medications we've already referred to. Medications to control the blood sugar. And of course, it's more important to control the blood sugar, but don't control it too much. So we have to be careful not to overtreat the hemoglobin A1C. For people at risk, we probably want to keep it in the 6 range. We don't want it to get below that for sure. And in some patients, we may even want to keep it a little bit higher, even sometimes 6.5, maybe even in some patients 7. But we don't want the hemoglobin A1C to get too low because then people would have a risk for hypoglycemia. The next is blood pressure. So we want to be very careful to keep the blood pressure under control. And at the same time, we don't want it to get too low because the low blood pressure can cause a decrease in cerebral perfusion and it can cause us to faint and fall. And sedatives, sleeping pills, anxiety medications, antidepressants, and painkillers are all in that category. So what about blood sugar control? Well, people who have a low blood sugar, the low blood sugars are related to emergency room visits. They looked at 201,705 adult diabetics. 9.06% of the hypoglycemia episodes were related to ED visits. About 9, well, it's actually less than 9%. 9 per thousand episodes of hypoglycemia were resulted in the emergency room. The risk increased, however, in the patients over 75 years old. So it went up to by about 50%. It also went up when people had a lot of complications. For example, people who had diabetes, who had a lot of the neurologic problems associated with diabetes, people who had a tendency towards hypoglycemia, people who had hypertension, had heart disease, who had numbness in their lower extremities. A lot of these people had a higher risk of falling. So it's related to both a low and a high hemoglobin A1C level. If the hemoglobin A1C is too low, you're over controlling the diabetes, you can fall. But likewise, if you have a high hemoglobin A1C, you can also fall. So you have to be very careful to keep diabetes under good control. I'm a big believer in continuous glucose monitoring, particularly in patients who are on insulin. What about hypertensive medications? They looked at 4,961 patients over 70 years old, and they were followed for 3 years. 9% experienced a fall. In patients who had a serious fall the prior year, being on blood pressure medications was associated with a chance to fall again. In other words, there was a high risk that if you were on blood pressure pills and you had a fall, you were going to have another one, and it could even be worse. So a patient who is on blood pressure pills, who has a fall, needs to speak to their doctor about maybe reducing the blood pressure pills and letting the blood pressure be a little bit higher, not get it so aggressively controlled. What about sedatives? Claims data from the insurance companies looking at 1,699,913 claims from Medicare patients over 75 years old noted that twice as many people fell when they were using a sleeping pill. The mortality rate was 15 times as high. So this is very dangerous. Think about sleeping pills in patients and If you're a patient, think about whether you really, really need a sleeping pill. I don't give sleeping pills very often. In fact, I can't remember the last time I even refilled a sleeping pill on a patient. What are other reasons why people have mechanical falls? Well, this is just a good catch slide, summary slide. A previous fall, age, visual disorder, a gait disorder, a loss of balance, muscle weakness, dehydration, nutrition problems, diabetes, heart disease, kidney disease, and other chronic diseases. Now, these are non-mechanical falls, but they all predispose to a mechanical fall. Who is at high risk for a fall? People that are older, people who are debilitated. In other words, you can be older and not debilitated, or you can be maybe a little bit younger and be debilitated. So I would say debilitation is the main risk more than age. Living alone is a risk for a fall. Having a visual impairment, glaucoma, if it's not treated properly, macular degeneration not treated properly, anything leading to bad vision, diabetes, for example, cataracts. Without good vision, it's very easy to fall. Improper footwear, a neuropathy, bunions, arthritis, things that make your feet hurt, that make it really painful, or things that make your legs numb can also increase the risk of a fall. A heart disorder, a rhythm problem called an arrhythmia, atrial fibrillation, heart failure, a heart attack, they all lead to a higher risk of falling. Dehydration, postural hypotension, that can lead to a fall. And with chronic kidney disease, particularly loss of muscle and bone mass. And then finally, even uremia and inflammation can all increase the risk for a fall. What about lack of exercise? Lack of exercise is a common reason why people have falls. People that are sedentary, that just sit around all day and don't get up and walk around and don't exercise, they're going to have muscle breakdown because your body, if you don't exercise and use your muscles, your body says, oh, we don't need that muscle. Let's tear it down and do something else with it. And if you have metabolic acidosis, which is very common in the kidney population, that causes you to have a higher risk for a fall. A loss of muscle mass can also lead to a loss of balance. Inner ear disorders can also lead to a loss of balance, and that happens as we age. What about dialysis patients? Falls are mostly at the end of the treatment when the blood pressure is low, the fluid status is low, their volume depleted. They have a neurologic problem where they can't regulate their blood pressure called autonomic insufficiency. The volume is related to salt. So if you're salt sensitive and you just went through a really good dialysis, your blood pressure may fall. Medications, metabolic alkalosis, hypokalemia, and having the potential for seizures can all lead to a higher risk of a fall when you're on dialysis. What about hitting your head? Well, if you're on dialysis, you're going to fall. There's a very good chance you might fall by the scale, for example, after weighing, and you'll fall forward and you might hit your head on the front part of your head. You may fall back, hit the back part of your head. It's also after dialysis, you're anticoagulated with heparin. You have a risk. And so we have a rule in our dialysis unit. Anybody that's fallen always gets a CAT scan. We always ask patients, did you fall? Yes. Did you hit your head? Oh, I don't remember. Never mind. We're going to send you for a CAT scan. And before we put anybody on an anticoagulant, they always have to have a negative CAT scan because we don't want somebody to have a very subtle subdural hematoma or a very subtle bleed in their brain and all of a sudden get on heparin and fall and get really, really sick. We don't want that to happen, and we try to prevent it. How do we prevent a dialysis fall? Just like what I did. Make sure that we assess for a fall risk, and if they did hit their head, or if they did fall, we're going to get a CAT scan. Do the fall risk survey. Accompany a high-risk patient to the scale or to the seating area after they finish dialysis. Don't let people drive. We actually once had, it wasn't my patient, but I heard about it. A patient drove after dialysis and they got confused and they drove into a store right through the window. So it's really important that patients who just finished their dialysis, they get to go home and rest, but we don't want them driving, at least until we really know they're stable. Be sure we're using walkers and canes and wheelchairs and monitor that blood sugar. And the dialysis patient, monitor the blood pressure, make sure they're on vitamin D, and encourage the patients to be more active. Make sure if they're sitting in that chair, we have a captive audience, we should sit down with them and explain to them how important it will be for them to exercise on all fronts, including the risk of falling. We developed a fall survey that is very useful. You might want to check it out. We can get a copy to you and have your dialysis unit do this, because this will sort of give your dialysis unit an indication that you could fall, and they might want to be aware of that so they can tailor a program that's for you. What do we do to prevent falls? Number one, we assess the patient, we individualize them, we put them in a balanced program, exercise them, make sure they're wearing appropriate footgear, review their medications. If they need it, give them a walker or a cane, fall-proof the house, and make sure that we're looking at the dietary concerns as well. How do we prevent the non-mechanical fall? The prevention of a non-mechanical fall includes frailty, stroke, and dementia, being aware of that, vigilant, offering them an assisted device, adjusting medications for age, condition, avoiding medications when necessary, making sure the patients are seeing an eye doctor, checking the patient for balance. If their balance is not good, sending them to a clinic where they can get some physical therapy to help with balance, working with patients on the walking, on their gait. They may need to see a podiatrist. Muscle weakness is a big problem. We need to make sure our patients are doing exercises, even simple exercises, will help prevent the resistance related loss of exercise. So if you don't do resistance exercises, your muscles weaken, but you can stop that by doing resistance exercises. Diabetes, we don't want to overcorrect it. We want to evaluate for morbidities. Heart disease, we want to manage the arrhythmias, and we want to make sure the patient's not in heart failure. And with chronic kidney disease, we want to manage acid-base balance, vitamin D, muscle changes, nutritional changes. And of course, we want to manage dehydration in the dialysis patient and elsewhere. And so it's very important that people don't fall and that they don't get dehydrated, because being dehydrated can give them a higher risk of falling. So how do we prevent the mechanical fall? Well, we want to fall-proof the house. Grab bars, slip-resistant carpet that doesn't wiggle or move around. Be careful with clutter with pets, pillows, and ottomans. Dogs and cats are really, really cute. We all love our dogs and cats, but it's very important that they are not where you plan to step. So if you have a little doggy and you're going to have to get up, let the little doggy move over a few feet so that you have a pathway, and be aware of that dog so you don't trip over the dog and injure yourself and the little doggy. How else can we foolproof our house? Night lights. I am a big believer in the night light. You can go to Home Depot, anywhere, buy a night light, get them on Amazon, hook it up. It's dark during the day. Nobody even knows it's there. But at nighttime, it lights up. It gives enough light, just enough light to keep you from falling and breaking your neck. Avoid slick floors. Always use handrails. Always, always, always use the handrail. And be careful of that towel on the floor. After you've taken your shower and you just drop that towel on the floor, be careful. It's uneven and you can slip on it. Be very, very careful. What about clutter? Well, here, cowboy came in after a rough day of bull riding. He threw his hat and his boots and his Wranglers and his shirt, threw them right on the floor, crawled into bed. He got up in the dark, he tripped over everything, and he fell down, but he didn't hurt himself. You know why? Because he's a cowboy and he's extremely aware of the risk of falling. When you ride a bull, you are going to fall. You want it to fall. You want your fall to be after 8 seconds. You know you're going to fall, so he's conditioned. so that he doesn't fall, or he does fall, but when he does fall, he doesn't hurt himself. So that's the one thing you do want to do, is work on ways that you can recover if you're about to fall. Or if you have to take a fall, make sure that it doesn't hit a part of your body that you may regret, like your brain or breaking a hip. Chances are the cowboy's going to be all right, but you won't be. In other words, the risk of a fall in an older person that leads to a serious illness is higher than the risk of a fall in a rodeo star. But it's really easy to be proactive and leave everything on the floor, and you just sort of have to discipline yourself if you have kidney disease. Well, it's important we get into shape, and resistance exercises, balance exercises, and learning to fall. These are the three things that we're going to spend the rest of our time very briefly talking about. What can I say? Lift weights, do elastics, whatever it takes. If you do that, you'll keep your muscles strong. These muscles are 76 years old, and the only reason I have them is that I exercise every day. But if you don't exercise, you lose your muscles very rapidly when you get old. There's a study that looks at accelerometers, these little things that you have in your iPhone. People that have lots of steps, people that are active on the accelerometer have a very low risk of falling, a 20% lower risk of falling. Why is that? It has to do with this product called mTOR. And mTOR is so well known in the muscle building field that they even have mTOR apparel and very nice shirts made by the mTOR company. So let's talk about mTOR. Okay, mTOR comes from a rapamycin, which was discovered in Easter Island. And there's a long, interesting story about it, but I'm not going to talk about it right now. mTOR stands for the mammalian type of target of rapamycin. Rapamycin, of course, we used in transplant patients for years. We now use other drugs that also work on the mTOR target now. We've improved. And mTOR stimulates cell growth when you at least rapamycin are hitting or stimulating the mammalian target of rapamycin causes cell growth. If you exercise and eat amino acids, it'll stimulate muscles. Stimulate mTOR will stimulate muscles. When fasting, mTOR is inhibited, and that stimulates this process called autophagy, or recycling, where your body doesn't think you need things, or it wants to conserve energy, and it has to conserve energy, and that's called autophagy. It conserves it by breaking things down. Some of the things that breaks down are old and need to be broken down, but sometimes you can overdo it. The KDIGO guidelines state that they recommend that people get about 150 minutes of exercise a week. So that's about 2.5 hours a week of exercise, but you can divide that over the whole week. So you have to lose it or use it. If you don't exercise, your muscles deteriorate. And if you're bedridden or if you go into space, your muscles are going to deteriorate. So you have to exercise to keep your muscles from deteriorating. And they've been doing a lot of controlled trials, and every one of the trials shows that people who exercise, they increase their quality of life, they improve physical function, they reduce their body mass index, they lower their blood pressure, and they generally do better. So exercise is really helpful if if you have kidney disease. So what happens is these little chains called ubiquitins, they will attach to a muscle if the muscle is breaking down, and they'll bring it into this cycler called a proteasome, and it'll break down the muscle into amino acids. And if you don't use a muscle, it's going to happen. So what about balance? Balance is very, very important. There are a group of exercises called the Otago exercises. And there are basically 12 of them. Knee bends, backward walking, walking in a figure of 8, sideways walking, heel to toe stand, heel to toe walk, standing and balancing on one leg. And if you get good at it, do it lifting weights and do it on a Bosu ball. The heel walk and the toe walk, the heel toe walk backwards, sitting to stand, and stair walking. So this isn't the Olympics, but it's still very simple exercises that can keep you in tone so you can maintain your balance. Now, if you're going to fall, then be prepared. Be able to lean forward. If you get off your balance when you're leaning forward, take a step forward real quickly with one foot and reestablish your balance. Do this on the side, do this backwards. If you can learn to have a habit of putting that leg out when you're about to fall, it will help you prevent falls. It's helped me several times. So I just want y'all to be aware of that. So the book that I recommend is called Understanding and Preventing Falls. And it's written by me, and I spent a lot of time working on this book because it's something that I feel is very important. And I think you'll enjoy it. And so if you're interested, I'd love to see more people read it. You can download it on Kindle. It's not really expensive. You can even rent it, or you can get a friend to buy it and you can borrow his or hers. But it's a great book. The other book that I wrote that talks about exercises is Staying Healthy with Kidney Disease. And that was a very good seller I wrote a couple of years ago, and it's very well worth reading to help you understand kidney disease. Well, that's all for today. I'd like to thank you very much. And I'm available if anybody has any questions.
Thank you, Dr. Fadem. That was a wonderful presentation. I have a few questions I'd like to ask you. From talking to AAKP members, falling is something that their doctors hasn't brought up. When and how is it best to start having this conversation?
I would be bold and just tell your doctor that you had a friend that fell or you fell. You can always say, I'm asking for a friend. A lot of us do that. But what you can do is tell your doctor you want to know what kind of programs she or he has available to help you to be in good condition so that you can minimize the risk of falling. Just ask that question. And if you ask it, the doctor will say, I'm glad you asked it. We ask every single patient that comes into our office if they've fallen recently. And if they do say they've fallen, then we go over very carefully how we can prevent them from falling. To me, preventing a fall is one of the most important things I can do as a kidney doctor.
How does medication management play a role in reducing fall risk, especially in someone taking multiple medications?
Excellent question. Many patients who fall are on a bunch of medications and they get dizzy easily, their blood sugars drop, or they're groggy and sedated. So it's important that you try to minimize the numbers of medicines that you're taking, especially if you're on a sedative or a painkiller or a sleeping pill or an antidepressant.
What are some of the early warning signs that someone might be at an increased risk of falls, and how can these be addressed?
As a patient, you can recognize that you're going to fall or about to fall because you lose your balance, you get dizzy, or you start to feel faint. These are the telltale signs that you might have. Your friends and loved ones may notice in some patients that they're losing their memory, they're not as quick, their balance is off, their gaits, they have trouble with their gait, and these patients would have a risk of falling.
And lastly, what are some practical modifications that can be made in the home to help reduce fall risk, especially for someone with mobility issues?
Since 16% of falls occur in the bathroom, make sure that if you have one of those big tubs, you have bars so you can hold on to them. And you have to be very careful. Your blood pressure can drop during a hot bath, and you might not do well if you try to stand up too quickly. Be very careful. The second thing is grab bars. Put grab bars in your shower, put grab bars by your toilet, have grab bars everywhere. And the third thing is Siri. And no, please, no iPhone, don't do that. But whenever I say Siri, Siri becomes active, and she just did. And so basically, if you're falling and you're on the ground, you would ask Siri, say, can you call somebody? I'm falling. And she'll do that for you, or whatever you have. If you have the Android, whatever the Android has, it's very important when people fall, they might not be able to get up. So if you need to have some sort of assistance, so keep your phone with you so that if you do go into a place where you're about to fall, you can get up. Falls can also occur on the way at night when you get up at night. So make sure you have night lights. Make sure you never go down the stairs without a handrail. Make sure that you're very careful of that surprise step, that little sunken living room step that we talked about. Make sure you're wearing the right footwear, and make sure that if you go for a walk outside, you have a hat. There are a lot of things you can do to prevent a fall. And that book has all of them. And you can write me and I'll be happy to go over the rest.
Again, Dr. Fadem, thank you. I know your shared insights and expertise has truly resonated with our audiences. We are grateful for the time and effort you put into joining us and delivering such a valuable presentation.